we have a very young patient.
Ay, voy a empañar, doctor.
No, yo te explico todo lo que voy a decir.
Okay.
Okay. We have a very young patient who I've known for a very long time, who presented today with an ulcer on the bottom of the left great toe. The past medical history is a little bit wishy-washy. I'll show you guys the x-rays as well. But, Patty, go ahead and show everything.
El alicate se lo puse acá.
Sí, tengo este y tengo
Okay,
este,
okay.
pero podemos usar este también. Este es un poquito
Okay,
mejor.
no problem.
So, you know, ¿usted no tiene diabetes?
Sí.
Okay, so the patient, yes, is diabetic. What we're gonna go ahead and do is I'm gonna debride some of this peri-wound callus. There's undermining. I've used that term before. See, this is healed. ¿Quién se dio cuenta de esto?
Yo.
I'm asking the patient who noticed this, right? ¿Cuándo?
Eso hace como 2 semanas que yo me estaba curando.
2 weeks ago.
Y entonces vi como que estaba como medio hueco por dentro. Entonces hice así y lo alé. Y botó muchísima sangre y se quedó así. Entonces yo me comencé a darme mejores cuidados porque yo no sabía que eso estaba así. Y entonces...
Ladies and gentlemen, what I'm basically doing is I'm removing all the the surrounding callus to demarcate really the size of the defect. That's what I'm doing right now. Very carefully, just trying to remove all of this callus. Okay, blood, that's good. Okay, so, you know, there's a curveball here, and I'll show you guys what it is. This is what. See? ¿Se dio un golpe?
No.
No trauma. ¿Cómo tiene la diabetes?
Cuando la última vez que yo me hice los laboratorios, me llamaron de allá y me dijeron que todo estaba bien, que todo estaba normal. Y esto ha sido últimamente así. Y yo no como azúcar, doctor.
Sí, yo sé.
Yo me cuido mucho. Por eso es que estoy tan flaca, que yo como estoy en el pellejo ya.
So what I'm going to do now is the probe to bone exam. ¿Tiene sensación o no tiene?
Sí, yo tengo sensación.
¿Esto le duele?
No.
No, okay. Again, the probe to bone exam is not, it's not doing this. Right? Because if you go, it's gonna into the bone. It's a very fine, right? Like this, right? Just. What am I looking for? Dr. Wagner, what are you looking for? Bone. There's no question, it's really, really close. I can feel it here. Patty, feel this. Right there, push down. Push in a little bit. Right?
Mm-hmm.
Okay, so the patient has psoriasis. Psoriasis. I gotta speak louder. People are telling me to speak louder. Patients with psoriasis have something that is called also psoriatic arthritis. Just like rheumatoid, kind of similar but different. And she's had this psoriatic arthritis for a very long time. This is how we met many, many, many moons ago. In a very large rheumatology practice. So our concern is we already took x-rays. Now we're gonna go and take a look at the x-rays and I'll show you guys what is our concern here. Follow me. So I'm covering obviously patient's name. So this is the full, okay? The great toe. We have two bones, this one and this one. The patient, you see the bone, it's very, very wishy-washy again. It's kind of like, you know, it's very, she has a lot of osteoporosis. You can kind of see through, you know, the bone, but this bone is okay. Now this bone is supposed to be out to here, right? But Dr. Wagner, where's the rest of the bone? Someone took an eraser and basically erased the bone. Our concern here, ladies and gentlemen, is possible bone infection, chronic bone infection. That the bacteria basically inoculated the bone and basically just, you know, set up a little tea party and just started eating away at all of the bone. So she may have chronic osteomyelitis, chronic bone infection. Bacteria has continued to just basically chum on all that bone. But again, do we see these changes with possible, you know, underlying psoriatic arthritis? Question mark. How do we distinguish? Very simple. We take a little piece of the bone and we send it out to have it analyzed. It's called a bone biopsy. So just like, you know, you go to the dermatologist, you have a little lesion, they take the little lesion, they shave it, or they do whatever it is, they send it out and they have it analyzed to see if it is a melanoma or a squamous cell carcinoma, whatever it is. That's exactly what we do. We make a tiny little incision and then we take a little piece of bone and we send it out to have it analyzed. For what? For bone infection. If the patient has bone infection, the patient will probably need a toe amputation. I will definitely keep everyone afloat on this patient's progress. Again, the patient is diabetic, very unfortunate. You know, when we talk about you know, a true epidemic of grand proportions, we continue to see it every single day here. Dr. Christian, do you want to say anything? Let's get Dr. Christian in there.
Hi.
What are your thoughts?
I think the woman definitely has osteomyelitis in the distal phalanx, according to conventional radiographs. So
Is she going to the hospital?
she's going to be admitted and have a vascular consult.
A plumber?
Yeah, the wound care and a bone biopsy to start, and then if that confirms the osteomyelitis, probably followed up with a hallux amputation.
Which is exactly what I just said. Okay. Like always, www.jawspod.com, Instagram, Dr. Toe Jam, Jawspod.you, Facebook, and last but not least, our YouTube channel, Jaws